Welcome back. Here's my friendly reminder to put your name and credentials in the comment box during this next session. Please remember, it's your responsibility to do that, and if you fail to do that, it might result in you not getting CE for that particular session. Now, about our next speaker. Lane Cook is a Knoxville psychiatrist and someone we've worked with for a number of years. He's presented here at the symposium multiple times. And you've probably heard me reference, he's recommended a bunch of people today. Well, he does that, but he also is quite willing to be volunteered to speak as well. So let me tell you about Lane. Lane Cook is quite well known here in Tennessee. He's avidly been involved with the symposium annually, and he's a frequent presenter at the symposium. And this year recommended a number of faculty as well. He is the chief medical officer at TMS of Knoxville, as well as the chief of psychiatry at one of our sponsor organizations, Cornerstone of Recovery. So please welcome Lane Cook.
Hello, I'm Dr. Lane Cook. I'm the Chief of Psychiatry at Cornerstone Recovery, the owner of TMS of Knoxville, and a psychiatrist in private practice. Welcome to the 23rd Annual Fall Psychiatric Symposium. My presentation today is entitled Neuromodulation, Better Living Through Electrons, Photons, Sound Waves, and Other Cool Stuff. Probably dating myself by using the word cool. So let's get into it. Here are my disclosures. I am a speaker for Alchemies and Takeda. That will not be discussed today. Medications will not be discussed. I already told you about the second ones. I'm a former consultant to the Goodman Center, and my discussion about that is that they do utilize the bridge device, which I will be talking about. I have no financial arrangements or connections with them anymore. I will be talking about off-label uses. I will be talking primarily about devices, not medications. These are devices that are here now, devices that you can find in the US, and devices that are international in scope, not here, and some of them are still pretty much in the research areas. So here are the objectives today. I want to review the concepts of neuromodulations through several different modalities that I talked about, learn about the techniques and what's available now and here and what's available regionally, research trials, and at the end, I'm going to give you a bonus. I'm going to talk about how I prepare for these talks and how you can too, through searches, the National Institute of Medicine's PubMed. And the great news is if you've ever tried to get a full article, but you don't want to pay $30 or $40 for it, I'm going to tell you how to get it for free. So stay tuned. So who said this? I'll let you read that. A lot of knowns and unknowns, with the last sentence being there are things that we don't know, we don't know. Well, it turned out to be Donald Rumsfeld, who was Secretary of Defense twice. And he was talking about how intelligence on terrorism, which is very difficult to weed through. But you probably know that quote is, you don't know what you don't know. And so here's a couple of questions to see if you know. Did you know that red and near infrared light emitting diodes can unclog your brain to improve Alzheimer's and chronic traumatic encephalopathy? How about a simple 9-volt device that can eliminate the suffering of tinnitus, and that ECT and TMS are 5 times more effective than meds at helping treatment-resistant depression? So here's a few necessary definitions in a graph. So neuromodulation is the alteration of nerve activity or synaptic strength through targeted delivery of a stimulus, such as electrical stimulation, magnetic pulses, light or chemical agents to specific neurological sites in the body. As I said, I'm not going to be talking about pharmaceuticals. And so an interventional psychiatrist is one who uses neuromodulation. So how do you get a device, a machine, to market? In the US, they're called Fda Cleared Devices. You probably think in terms of the term FDA approved. That's reserved for pharmaceuticals. And the clinical trials differ between the devices and the drugs. Now, although the nomenclature is sometimes used in devices as it is in pharmaceuticals with phase 1, 2, 3, and 4, There's also a different nomenclature about pilot studies and feasibility, pivotal, and post-marketing studies. And as you can see, the numbers and devices are smaller. And it is, we also talk about in a medication, we talk about comparing the medication to a placebo, which is an inert ingredient, usually, sometimes an active one. But in devices, we talk about a sham. The sham device looks and sounds and feels like the device. You have to simulate that so that neither the patient nor the clinician knows if you're getting the active treatment or a sham treatment. You're probably a little bit familiar with these terms about wavelengths, and the different parameters of wavelengths can affect the outcome of the treatment, such as the wavelength, which is the distance between identical points, such as the troughs or the peaks. And the wavelength of a pulse of light, for example, can activate certain molecules and nerves and organelles like the mitochondria that if you get outside that wavelength, it does not. The amplitude is how high the difference between the origin and the crest or the trough. In transcranial magnetic stimulation, the amplitude is based on something called the motor threshold, and it determines the effectiveness. The frequency is how often you do it. You're going to see 40 hertz, or hertz is the times per second, cycles per second, mentioned several times, and we think that activates microglia to scavenge things like beta amyloid in the brain, and the speed, which is the wavelength time the frequency. So the mechanisms of action are by stimulating the neurons, you create an action potential. The cell becomes depolarized. The difference between the electrical charge on the inside and the outside changes. By increasing the strength of the synapse, you would create what we call long-term potentiation, which is the basis of memory, which you do over and over again. You learn the lyrics of a song or your chemistry lesson you need to know. By decreasing the strength of the synapse, it's called long-term depression, and there are times that you want to do that. You want to dial down the brain. So let's have a little 4 minutes of some neuroscience here to explain this.
Welcome to 2 Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss long-term potentiation, or LTP. LTP is a process by which synaptic connections between neurons become stronger with frequent activation. LTP is thought to be a way in which the brain changes in response to experience, and thus may be a mechanism underlying learning and memory. There are a number of ways in which LTP can occur. The best-known mechanism involves a glutamate receptor known as the NMDA receptor. In NMDA receptor-dependent LTP, glutamate release first activates a subtype of glutamate receptor known as the AMPA receptor. NMDA receptors are found nearby these AMPA receptors, but are not activated by low levels of glutamate release because the ion channel of an NMDA receptor is blocked by a magnesium ion. If frequent action potentials cause greater stimulation of AMPA receptors, however, this will cause the postsynaptic neuron to depolarize, which eventually causes the voltage-dependent magnesium blockage of the NMDA receptor to be removed, allowing calcium ions to flow in through the NMDA receptor. This influx of calcium initiates cellular mechanisms that cause more AMPA receptors to be inserted into the neuron's membrane. The new AMPA receptors are also more responsive to glutamate and allow more positively charged ions to enter the cell when activated. Now the postsynaptic cell is more sensitive to glutamate because it has more receptors to respond to it. Additionally, there are thought to be signals that travel back across the synapse to stimulate greater levels of glutamate release. All of this makes the synapse stronger and more likely to be activated in the future. This process is also associated with changes in gene transcription in the neuron, which can lead to the production of new receptors or modifications to the structure of the cell. These changes seem to be important for making the increased responsiveness of LTP long-lasting. Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss long-term depression, or LTD. LTD is a process by which synaptic connections between neurons become weaker. It is the opposing process to long-term potentiation. Although the functions of LTD are not completely understood, it's thought to be important to memory formation, perhaps by resetting previous synaptic changes to allow for new memories to be formed via long-term potentiation. There are several different mechanisms by which LTD may occur, but the best understood of them involves the same glutamate receptors involved in long-term potentiation, NMDA and AMPA receptors. NMDA receptors are typically blocked by a magnesium ion, which is only removed if the postsynaptic neuron becomes sufficiently depolarized, as can occur through the activation of the AMPA receptor. When the block is removed, calcium is able to flow into the neuron, causing further depolarization. While long-term potentiation typically occurs after brief but high-intensity stimulation of a postsynaptic neuron, LTD can be caused by prolonged low-intensity stimulation or stimulation that occurs after the firing of an action potential. With the type of modest stimulation that results in LTD, there is not enough depolarization to cause widespread removal of the magnesium blockage of the NMDA receptor. However, there is enough to cause some NMDA receptors to allow calcium into the cell. This low level of calcium is insufficient to activate the enzymes that facilitate long-term potentiation, but it is thought to activate a cellular cascade that causes the removal of AMPA receptors. This reduces the number of glutamate receptors on the postsynaptic neuron and weakens the synapse. LTD may also result in other changes that decrease the strength of synapses, like a decrease in the amount of glutamate released from the presynaptic neuron. And it also can involve other receptors like metabotropic glutamate receptors or other neurotransmitter receptors altogether.
So he mentioned how if a postsynaptic impulse comes in after the action potential, that can create long-term depolarization. So how does this work? It works through something called spike timing dependent plasticity. And so when the action potential arrives from the presynaptic neuron at the synapse before the postsynaptic action potential, that's when you strengthen it, and that's when you get that acceleration and that bump up in the activity. But if it arrives after that, then you get the decrease in it, and that's the long-term depression. And we can adjust whether we want to have potentiation or depression based on different things like pulses. So there are pulse parameters, and they determine whether brain activity is increased and learned or it's decreased. So what are the main factors in neuromodulation? Just like real estate, it's location, 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 and it's timing, timing, timing. So the location is, okay, where do you stimulate? If you're stimulating over the head, over the brain, you want to stimulate the left dorsolateral prefrontal cortex for the treatment of depression, and other areas for other kind of problems, over the motor cortex for pain, for example. And whether you stimulate gray matter versus highly myelinated white matter makes a difference. The timing is very critical. Overall stimulation tends to be inhibitory, but if you do it at a high frequency, in the case of TMS, anything over 5 hertz, then you increase it and you cause long-term potentiation. The total number of pulses, how long you do it, the timing and the rest between it make a lot of difference. If you look at the market share of neuromodulation devices, you can see pretty rapidly that the lion's share is for neurology, for things like pain, deep brain stimulation for Parkinson's or essential tremors, sacral nerve stimulators, which work on the bladder, vagus nerve stimulators, which have been used for depression, but mainly used for seizures. And TMS and the others is a small amount of the pie. So again, I talked about here, near, now, not here, but now, and not yet, but not here. And I'm going to show you some examples of that. So for neuromodulation for mood and anxiety disorders, there are 3 main ones: electroconvulsive therapy, otherwise known as ECT, transcranial magnetic stimulation, known as TMS, and deep brain stimulation, DBS. And because of the cost and the mechanisms and the duration and all sorts of factors, these are generally reserved for severe cases. So what am I not going to cover today? Well, I'm not going to cover deep brain stimulation for a couple of reasons. It seems to be a lot more appropriate for neurological conditions like Parkinson's disease and essential tremor. There were mixed results in depression. We had some initial excitement when you did a double-blind sham control. The differences tended to disappear. There is an FDA-cleared OCD protocol. This requires brain surgery. You're actually opening up the skull and putting a stimulating probe into a certain area, sometimes on the surface, often deeper into the brain. There bad things can happen. You can have death. You can have infection. And the other issue is it's really not practical around here. I had a patient who failed ECT, every antidepressant combination in the book, and even 2 courses of TMS. We looked at referring for DBS for research purposes for depression. The closest place was Emory in Atlanta, but you had to move there for 3 months because you have to be checked twice a week, and they have to monitor you for infections and things like that. So DBS is something I'm not going to cover. There's also something called optogenetics, where you introduce a virus, for example, as a vector to change the genes in the brain. And with the activation of light, which sometimes is invasive, you can actually change and get down to very deep, specific areas of the brain. But it's really seems to be more research, and the applications for the active, where you introduce a genetic change, is different. There's one that doesn't involve that. We'll get to that at the end. So the granddaddy is ECT, electroconvulsive therapy. And the story goes that Ugo Soletti, who was a Italian neurologist, had witnessed how butchers would slaughter pigs in a humane way by delivering electrical shocks to the side of the head, inducing a seizure. And then that postictal state of confusion and being dazed and confused made it easier and more humane to slaughter the pig. And we had noticed that people with schizophrenia, for example, had remission of their symptoms after epileptic seizures. And then people began to look at, well, could we give seizures to people? And they first used chemical like metrazole to induce seizures, but it really wreaks havoc on the skeletal system. There were vertebral fractures, terrible violent seizures. And so after looking at the butchers and the pigs, Serletti got the idea of, well, maybe I could deliver electricity to both sides of the head. And there's an early primitive device that looks to me like ice tongs. And the very first patient treated was a delusional schizophrenic with hallucination, and the symptoms cleared up. And this was in 1939, and ECT came to our shores in 1942. So what are the indications for ECT? Severe bipolar disorder, severe major depression, sometimes schizophrenia, active suicidal ideation. And it was used for catatonia, but that pretty much got eclipsed by IV lorazepam or Ativan, which is a whole lot easier to do. So now and then issues crop up that ECT's been around a long time. There haven't been sufficient studies and even moves to take it off the market. And so far that's been resisted. There's a very recent study that shows how beneficial it was in bipolar depression. ECT is probably the most effective treatment for severe major depression, with about a 60% remission rate. Unfortunately, ECT also has a fairly high relapse rate. About 60% of those patients within 1 year will require more treatment or different treatment. In this particular study, which was just published this year, it was the end of a 13-year study in Italy. And they found that about 72% of people with bipolar depression were responders. There was an 80% reduction in suicide risk, improvement in symptoms across the board, including psychotic symptoms. And most of these were very treatment resistant. So how do you do ECT? Well, the way that Serletti used it initially was in bitemporal. You put the electrodes on both sides of the head. We know now that that causes more confusion. And so using it over the non-dominant hemisphere, which for 90% of us is on the right, and using ultra brief, we now have decreased the amount of memory problems associated with it. ECT is conducted 3 times a week, typically Monday, Wednesday, and Friday, for generally 6 to 8 sessions. You have to have a motor seizure. It's done under general anesthesia with medications. And there are side effects. There's both retrograde and anterograde memory problems. It goes back and it goes forward. If you were to have ECT on January 1st, New Year's Day, there's an extremely high likelihood you would not remember Christmas or much of the 2 weeks before or 2 weeks after your ECT. There are side effects such as headaches, muscle soreness, and clenchings of the jaws. This is done in the operating room. There are 2 clinicians in town that do this at 2 different institutions. It's all outpatient now, I believe. And you have to pretty much be off work for 30 days. There's no driving, there's confusions. You can imagine these are older individuals, typically on multiple medications. So you've got to have somebody who would be able to manage the medicine so that there were no um, problems with compliance. So typically, it's not a good idea to do this with somebody who lives alone. Most insurance only requires a failure of 2 antidepressants. You may have heard of the Kupfer curve. This has to do with the phases about depression. When we talk about depression and antidepressant treatment, we talk about if you can get your depression rating scale numbers cut in half, that's called response. If it reaches a low threshold, which is different in each test, I'll show you, that's called remission. Before you get to remission, you might relapse. When you get to full recovery, unfortunately, depression tends to come back. One of the screening instruments that's widely available and public domain, you won't have to pay anything to get it. It's called the PHQ-9. We learned this little mnemonic in medical school for the symptoms of depression, the SIGI-CAPS, which is there. Sleep, interest, guilt, energy, concentration, appetite, psychomotor retardation, agitation, and suicidal thoughts. There are several different ones that we use, not only the PHQ, but something called the QIDS, the Quick Inventory Depression Scale. Numerically, they're identical. There's some differences. The Hamilton Depression Rating Scale 17 item is clinician based. The clinician comes up with the numbers. And then what was probably used more often than other ones, and we use for monitoring the progress of people in TMS, is the PEC Depression Inventory. Below this first line here is the remission line. If you get below 4, if you get a 4 or below with the PHQ or the QIDS, a 7 or less, a 10 or less on this, you get remission. That means you look good. Here's the numbers for severe, a 29 on the Beck, a 20 on the PHQ, and a 24 in the Hamilton. And for insurance coverage for transcranial magnetic stimulation, you have to have severe. If you get a 50% reduction, as I said before, that's called a response. You have to get response in 2 placebo-controlled trials of antidepressants to get on the US market. Well, due to long-term potentiation, the brain learns how to get depression. 50% of people with depression will eventually have a second episode. 75% of people have a second will have a third, and 95% of people with a third will go on to have recurrent. It's this reason that antidepressants lose benefit over time for many people, and there is a lot of the insurance companies consider failure for antidepressants to be treatment-resistant depression, but I'll show you some differences of that. So if you're a psychiatrist, I'm sure you're very familiar with the STAR-D trial, the sequence treatment approach to relieve depression known as the STAR-D. It was a multi-site, multi-year study looking at people with major depression. Most of them had averaged at least 3 episodes of this, published back in 2006. Here is how they did it. They pre-populated this algorithm and said, we're going to give everybody citalopram. I'm going to be bilingual here. Not everybody knows the generic names. That's also known as Celexa. And they looked for remission. If you didn't get in remission, you went to step 2. And 37% got remission. Step 2, you could use bupropion or Wellbutrin, sertraline or Zoloft, venlafaxine or Effexor. There was a small cognitive therapy arm, but it wasn't large enough and powered enough to achieve significance. You could add Wellbutrin to the citalopram or buspirone, which is not an antidepressant, but augments it. And then you start dropping down. On level 3, if you were in a remission, you could use mirtazapine or Remeron or triptyline and tricyclic. You could augment with lithium or T3 thyroid hormone. If that didn't work, you went to an MAO inhibitor, tranylcypromine, or use what Stephen Stahl calls California rocket fuel, to use Remeron and Effexor together. Well, why would you use neuromodulation if you have all these wonderful antidepressants? Well, it becomes very clear right away. You see what happens is you have a 37 to 39%. And you'll see different remission rates because they were using different things like the Hamilton and the Quiz. But in this slide, it showed about a 37, 39% remission rate on step 1, drops down to about a 30, 31% at step 2, then it's cut in half. It drops down to about 14%, 13%. And Mark George and Harold Sackheim in an editorial said, we really should call failure of 2 antidepressants treatment-resistant depression. And it only gets worse after that. The average patient that I would treat with TMS has failed 9 to 10 antidepressants in augmentation trials. And your chances of getting better with the medication are basically kind of slim to none. So Tom Insel, who was the director of the National Institute of Mental Health, said it very clearly. Said basically the inconvenient truth is that our treatments are always just not good enough. And so the next thing that came along after ECT was transcranial magnetic stimulation. At first, it was only covered by Medicare. Now most commercial insurance policies cover it. They want to see typically 4 antidepressant trial failures or an intolerance. If you've had terrible side effects to medications, that counts. And most of them require a trial of evidence-based psychotherapy, which is generally CBT. Treatments are done Monday through Friday for 6 weeks and then a 3-week taper. At first, there was only 1 device. Now there are 7 devices from all over the world. The first device to get FDA clearance is made right here in the United States, and then the Israeli device, and then everybody else hopped on board. The Apollo device wins the design award for its avant-garde one there at the bottom. The Russian device, the Cloud TMS, this is a very sturdy device. It looks like it go up in a Soyuz capsule. The MagVenture and MagStem were really pioneers. They've used different names, and they've been around forever and had been used in research. They all have about the same equal effectiveness. TMS treatments show typically anywhere from the high 30s to 45% remission rates in clinical trials. They're much better in clinical practice for a variety of reasons, and remission rates are around 50 to 70%. And the good news is that the recurrence rate or relapse rate is much lower, around 32, 33%. And sometimes people do need to be retreated, which is half of what you see with ECT, and lower than things like ketamine and esketamine, which are having 40, 50%, and really looks like a maintenance treatment. So here is a cool coil that has an antifreeze-like circulating polymer in a closed circuit to keep the coil cool. Here's a COVID treatment on the left, but most people, including we do, use gloves as well and sterilize the equipment afterwards. So how does TMS work? The best explanation goes to looking at functional brain networks, and the ones that are involved in just about every psychiatric disorder, and especially in depression, are 3 main ones. The central executive network, which is mainly prefrontal, the salience network, and the default mode network. Since early brain imaging in the 80s with xenon-based cerebral blood flow studies and later positron emission tomography, we've known that depression shows hypofrontalis or low metabolism in the frontal areas, especially on the left side, which is how we decided to start with the left side. So basically, think of your central executive network as your computer, your office manager, the CEO, how you figure out things, your cognitive skills. The default mode network is the background. That's what's running in the background, biologically most active. And the default mode network has to do with some memory consolidation, but the default mode network has to kind of tone down to downregulate itself for you to focus. People with ADD can't do that, and that's a problem with them. And the salience network is composed of things called spindle neurons that are, not branching, but just look kind of like telephone poles, and they switch on and off the default mode network. In people with depression, the default mode network is responsible for the depressive brooding and ruminating that occurs. And so depression is that your central executive network can't be your internal therapist and cheer you up, kind of cheerleader. The default mode network is telling you terrible things, and the salience network is allowing it to have its way. So by using a stimulating treatment over the left dorsolateral prefrontal cortex, you hit all three of these networks. You have a very direct connection to nodes of the salience network and the central executive network, and you got pathways into the default mode network. Now, how you pulse this matters on the outcome. Typically, the first treatments were the 10 hertz, 37-minute treatment, then get dropped down to 19-minute treatment. The intertrain interval, they discovered that if you didn't give at least 2 times the amount of time you stimulate, like if you stimulate 4 seconds, you got to give at least 8 seconds off, or if you do them too close, you could have seizures. The frequency, a low frequency, decreases and causes long-term depression. A high frequency stimulates it, and the FDA cleared sessions are 36 sessions, 3,000 pulses. Now, drawing from animal models, we found you could do the exact same thing using something called Theta Burst. And theta is triplets of 50 hertz pulses, very rapid. They're done every 2 seconds with at 5 times a second, and that's in the theta range. And actually, you're nesting 50 hertz, which is in the gamma range, inside this. And we can decrease the time that it took originally 37 minutes, or the FDA standard protocol 19 minutes, which all but 2 devices can only do, down to 3 minutes and 10 seconds with this Theta Burst. And there are different types of Theta Bursts. You can also treat depression as well as some anxiety disorders and PTSD on the right side, but you use 1 hertz over there. Jonathan Downer talks about there's an anti-reward network on the right, and maybe you're stimulating that anti-reward. You're inhibiting the anti-reward. That's a double negative to give you more rewards. And you can do the same thing with continuous Theta Burst that keeps going. If the regular TMS feels like and sounds like a woodpecker tapping on your head, this one is more like a bumblebee. If you space it 8 seconds apart, that's intermittent Theta Burst, and it does the exact same thing and is now an FDA cleared protocol for depression. So can you use it for TMS for anything besides depression? Yeah. So let's say you're treating addiction and you want to increase the central executive network, you're going to use your basic 10 hertz left dorsolateral. But let's say you want to inhibit impulsivity. You're probably going to want to use a different coil over the middle part of the brain and give the kind of the medial prefrontal cortex. And this is Colleen Hammond's work that was done at MUSC. And Colleen has now moved on to Wake Forest, I believe.
Welcome to our approach for Artemis. We target 2 locations in the brain, the Dlpfc to increase that executive control circuit and the MPFC to decrease craving. We're using TMS to determine which approach is more effective. Each participant comes in for an initial visit, which consists of screening and questionnaires, and participants are asked to return for 3 visits, each consisting of a session of TMS, quickly followed by fMRI. At each of the visits, we find the resting motor threshold to determine each participant's dose of stimulation. For stimulation, we use 110% of the resting motor threshold. Linked below, you can find a video on how to find the resting motor threshold. During treatment, here is an example of our medial prefrontal cortex placement. Here is an example of our Dlpfc placement. Once the treatment begins, the researcher will raise the amplitude up to 110% of the resting motor threshold. For CTBS, the treatment is 5 minutes, and for 10 hertz, the treatment is 15 minutes. In our protocol, each participant receives a single dose to the medial prefrontal cortex, the Dlpfc, and a single dose of sham.
You're hearing continuous
During
Theta
the
Burst in
treatment, we
background.
prime participants by asking them to think about things that make them crave. We also provide them with visual cues during their treatment. After TMS treatment, we collect the amount of time from the end of treatment until the participant is in the MRI scanner. The participants are then placed into the scanner to complete a cue task. During the functional MRI scan, the participants are shown a series of alcohol cues. They are then asked to rate their urge to consume alcohol right now via a hand pad. The participants are then shown a series of neutral cues. They use the same hand pad to rate their urge to consume alcohol. During each of the visits, the participant is given one of the 3 treatments. They are then placed in the MRI scanner and we analyze their bold response to alcohol cues. We also take self-report of alcohol craving levels, as well as analyze the MR spectroscopy afterwards. Thanks for watching our video on Artemis.
So you got the Artemis from our TMS. We typically dose depression on 120% of the motor threshold, which we do by placing a coil over the left motor cortex and holding the person's thumb up and looking for finger twitches. With the medial prefrontal cortex, you actually have to have the person take their shoes and socks off, and you put it up on the vertex and look for their toes to twitch, which can be quite a challenge. Now, Mark George had published an article about a study of acutely suicidal people where they accelerated TMS and did, I believe it was 5 treatments in one day, and got something like 80% reduction in suicidality. So this made a big kind of big splash in the news recently this year, I believe it was, with the SAINT protocol that stood for Stanford Accelerated Intelligent Neuromodulation Therapy. What they did was they crammed all of the sessions in 1 week, in 5 days. 10 sessions a day, you have to give a little rest, 50-minute breaks. It was open label, and they got 90% remission. Now, let's talk about duration. Well, that dropped 30% in a month, and it dropped off further after that. So, and that's a much higher recurrence rate. It's double the recurrence rate, basically, of the standard treatment. So, if you had somebody severely depressed and in the hospital, but you're tying up 1 TMS machine for the entire week by doing that with 1 patient. You could probably treat 3 patients if you move them in and out pretty quickly at the same time. What was interesting was they showed, even with this 1 week with functional MRI imaging, that there were changes in the left hippocampus. You have these kind of stem cells in the hippocampus that grow new brain cells with TMS, ECT, aerobic exercise, lots of good things, psychotherapy. So look, we talk about location. Well, how do you get there? Well, some of these structures are deep down in the brain. TMS has a depth of penetration about 3 centimeters. The brain's way deep TMS probably 4, maybe a little bit more than 4 centimeters. So how do you get down there? Well, fortunately, we have these networks, and they connect to all different places, including areas on the skin of the head. You can use transcutaneous current that goes through the skin. You can use what's called percutaneous. And I'm going to show you probably the quickest neuromodulation there is in a moment. If you studied any anatomy, they have these wonderful things called the cranial nerves, and we had to memorize those, and also the name of the foramina that came out in the skull. And there's the 12 cranial nerves, and many of them are accessible for neuromodulation now. At least, I believe 8 of these have sensory inputs. I actually found a mistake in this. The facial nerve, it shows as pure motor, but next slide shows you that there's also a sensory aspect. Facial nerve is responsible for taste on the anterior 2/3 of the tongue. There's a lot of nerves going into the tongue, and believe it or not, one of the neuromodulations uses one of these areas. So you can use different ones, and the one that first got looked at and used was the vagus nerve. Vagus is Latin for wanderer. The vagus nerve basically starts out in your brain stem and goes all the way to your rectum, and it controls your gut, your heart, your lungs, your larynx, all sorts of things. So the first was vagus nerve stimulation, and this was this is available here in Knoxville, and it was used and is still used for seizures. You can get good seizure control with this, mainly for kind of resistant seizures. The ear, nose, throat doctor puts these electrodes through the carotid sheath around the vagus nerve, and then buries a battery, a small battery under the clavicle. And the clinician noticed that some of these vagus nerve stimulation epileptic patients had relief from their depression. So Mark George and Harold Sackheim, Lauren Marangale from my old institution, Baylor College of Medicine, John Rush, published studies looking at vagus nerve stimulation for depression. That was done here. I managed to have 3 patients implanted, 2 had remission. And it did very well for that. You could turn off the magnet or turn on with the use of a magnet. If a person with epilepsy had an aura that they were about to have a seizure, they could turn on and ramp up that by putting a permanent magnet over their clavicle. In TMS, in vagus nerve stimulation for depression, you did the opposite. You turned it off. Well, why would you want to turn it off? Well, because when it's stimulating and gives you kind of a robotic sound in your voice, you would be talking, and all of a sudden you're talking like this for about 5 seconds, and then you go back. Well, that's okay unless you happen to be singing in the choir or delivering a lecture. So you could actually tape it over that if you wanted to give a talk or sing or something like that. Well, here and gone, the Medicare approved it and then changed their mind a year later. They said there was not really enough evidence to show that it was effective, and they denied it. And I believe that no commercial insurance company ever paid for this. And it was a real sad thing, because you implanted this battery. 2 of my 3 patients got remission. You implanted this battery with a life of 7 years. And when the battery died, Medicare wouldn't pay for it to be replaced. Good news is, even though that's gone, maybe coming back, CMS, Centers for Medicare Studies, issued this national coverage determination for a pilot study. There was enough pressure to say, well, let's try this again. So there is a large study being done. And one of the things I want to introduce you to is clinicaltrials.gov. This is a government website that if you want to get a medication to market or a treatment to market or a device, you have to register with this, and you have to publish your criteria. And then if you have results, you do that. You can look up and see where people are recruiting for this, as I did for a deep brain stimulation. There are no sites in Tennessee for the vagus nerve. And it shows when it's recruiting, if it's finished or it's been stopped. So let's look at a real quickie that's here and now. To my knowledge, the Goodman Center, I actually introduced them to this device, learned about it for opioid detox. There may be other people that are doing this, and you can do this. And this is based on a device that was using the vagus nerve's inputs on the ear. Acupuncturists have known for 1,000 years that there are places on the ear that you can affect different organ systems and stuff, probably through the vagus nerve. And so since opioid detox is painful, they said, well, let's try this. And you actually have to kind of shine a light through the ear, because you don't want to get the arterioles there and cause too much bleeding. And this is how it looks. Very interesting and very quickly. And this is a heroin addict who's going to go through an easy withdrawal.
Were you using daily?
Yes.
Okay. And what kind of symptoms are you having right now? How are you feeling right now?
I'm anxious. I yawn a lot. My eyes water. My nose is constantly running.
Okay.
The body aches. And just along with the anxiety, definitely
Okay.
the shakes.
Okay. So what we're going to be doing is putting on this device. It's called the bridge device, and it looks a little bit like a hearing aid. It'll fits right into the palm of your hand. It'll sit right back here. It'll be secured with some tape. And let's see if we have it right here. Let me show you.
Opioid
This is what it
withdrawal
looks
is
like.
like the flu on
And
steroids.
what it does is it connects to certain little nerve points along the ear, and it conducts little impulses to some of your cranial nerves, and it just calms the brain down and helps relieve some of the uncomfortable feelings that you're having with the withdrawals. Okay.
Looked a bit skeptical, didn't he? Takes about 5 minutes to put this on. And they wear this for 5 days. Typical opioid detox would take 5 days and
That one?
a lot of misery a lot of times, even with buprenorphine.
2
So we'll be
days
back in 10
already.
minutes. Okay, so now it's all on.
Okay.
Do you feel a little bit of a pulsing
Oh,
sensation?
yeah.
Be honest with me and tell me how you're feeling, okay?
Right.
You have
Yes, ma'am.
any impressions right now? Anything you want to...
I'm so excited. This is mind-boggling to me.
Good.
It's like I'm in a fantasy land. Like, this isn't
No.
real.
Let me scratch. Yep, it's real.
And it's like I'm ready to just get out, go
Build
eat,
some dip.
go eat some food, go work hard.
Do you feel restless? Are you able to sit still? You feel calmer?
Yeah.
Yeah.
And rather than anxiety, it's like excitement. Just like, holy cow, this isn't. Words can't explain it. I don't know. I've never felt this before. Usually it's weeks of misery.
Well, good. It doesn't have to be.
20 minutes now. I feel like I can walk out the door. I haven't eaten in a couple of days, didn't have an appetite. I feel like I could go out and have me some lunch. And one of the big things is I'm always low energy. You know, that's part of the withdrawals. And now it's like, God, I'm excited. I'm ready to go out and get going.
You're smiling. That's a good first sign. Let's see, let's get this thing on. All right. Any sweating?
No.
Okay. Completely gone.
Yes.
Are you able to sit still? Do you feel restless at all?
No.
Any body aches, joint pain, muscle pain?
No.
How about the runny nose? Are you having any problems with the runny nose?
Stopped.
Stopped. Stomach issues. That's cramping, nausea.
No.
Vomiting. Completely gone?
Just hungry.
Hungry. Let's see. Put your hands out. Okay. Hands of the surgeon. Your anxiety compared to when you first came in, is it better or gone? How would you?
It's gone.
She's asking him the questions of the COWS, or the clinical opioid withdrawal syndrome. Many of them are, you have to ask them, you know, do you have stomach cramps? Do you have nausea? Do your legs restless? And like, there's some objective measures like pupillary dilation and constriction, blood pressure, pulse, tremors. We generally don't start detoxing if you introduce a mixed agonist antagonist like buprenorphine or Subutex too soon, you will precipitate withdrawal and the person will feel a whole lot worse. So you typically wait till the withdrawal is up around COWS scale 15. He started with in this study, they waited till they were 20. Really, you begin to see reductions in 5 minutes. In 10 minutes, they're usually pretty good. And you can see how the numbers get down to pretty much normal at 60 minutes. Really amazing device. Costs about, last time I checked, about $500 for this. The battery lasts 5 minutes and then it's toast. And some places do it in conjunction with an IOP, an intensive outpatient program. Really an amazing device. Now you can use a padded vagus nerve stimulator on the ear that may be helpful in anxiety and depression. Here's my good friend Mark George, who pioneered TMS for depression using this. You can buy these devices. They're not FDA cleared, and they can relax you or different things. Some gamers even use these devices to give them an edge. So let's talk about another cranial nerve. The trigeminal nerve is a sensory nerve for the face. Basically, and the tongue actually too. Basically, what you have is some devices that are in the preclinical clinical trials, and you got one out now, one that is used for ADHD, and it is FDA cleared in children ages 6 to 12. That woman looks suspiciously like the same woman in the bridge device, so she must be the neuromodulation model. And here she's putting electrodes. These are just stick on. There's no pain involved. And the child goes to sleep with it, and it stays on at night. And there was the study showing it was useful. When you look at a study, you want to look at the beginning and the end point. And I'm going to compare this. They use the ADHD rating scale. And these were moderate ADHD kids, and the scores were about 32, dropping down to 23, which was a 10-point drop. And you can see it, after the first week, you're seeing some pretty significant responses, and by week 4, it was you get this 10-point drop, which is a substantial improvement in symptoms. And this is, of course, during the day. To contrast it, I want to show you a couple of medications. There's the Oros Methylphenidate, also known as Concerta, lisdexamfetamine, also known as 5-ANTS. And they started out higher at 38, and they got a higher drop of 25 points. So again, look at 38 to 13 versus 32 to 23. And this seems to be comparable to what you would see with atomoxetine or Strattera. Not as robust, but still, no side effects, not going to dampen and blunt the child's emotion, where it's a lot of people, they feel like children feel like they're zombies with too much stimulus. Well, and so here's an interesting one. It's in phase 3 trial. This is an Irish company, and an Irish one. And let me show you this kind of funny little Irish lady here by the name of Patricia.
I got tinnitus about 4 to 5 years ago. I just woke up one morning and I had a buzzing in my head, and I thought, oh, there's a cold. A month and a half later, I was thinking, no, it's not a cold. So I went to the doctor, and then I went and had all the scans. I had an MRI scan to see what was wrong, and they said it was tinnitus. And it's literally 4.5, 5 years now. I started the trial February, March. And I will be quite honest, I kind of missed a few days to start with, before you got into the rhythm, I have to do this every day. And then when I got into it on the 15th of April, I woke up in the morning, and it was a Sunday, and I thought, there's something wrong. And my partner said, I said, there's something wrong. He says, yeah, you have no television or nothing. And I went, I can't hear anything, it's gone. And that was it. And it stayed gone until I finished. I think I finished the trial on the 18th of July, I think it was, or 18th of June, and it never came back. So basically what I did was I did a half an hour in the morning before I got up, and a half an hour in the evening when I came home from work. So that was, and the first week or so, to be quite honest, it was boring because you can't watch television, you can't, because you're listening to sound. But then I just read a book, and it was perfect. The half hour just went so quick. And plus the fact you didn't have to watch the clock because the machine was set in a way that once the half hour was up, it stopped, and you could put it on again if you wanted to. I don't know what exactly it does, but it works. You wouldn't think that putting just a little tongue tip that vibrates on your tongue and listening to music is going to get rid of something, but it does. I think I was supposed to give it back a week and a half before I actually did. I did say I was away. That might have been a white lie.
So it's paired with some Bluetooth headphones. There have been work with TMS and some other neuromodulations for tinnitus. Tinnitus or tinnitus is the ringing in the ear caused almost always by high-frequency hearing losses, and the brain unhealthily fills in those particular gaps in your hearing with white noise, whistling, something like that. Now, if you're wondering, why are you having this in a psychiatric lecture? Well, because it causes misery. You may not know this, but tinnitus is the #1 cause of service-connected disability in U.S. veterans. Veterans are people in the military around loud noises, guns, artillery, helicopters, aircraft. And when you do rating scales on it, you can't measure tinnitus. People can only tell you, it's like measuring pain. You can only, go by subjective stuff. But the most commonly used instruments called the tinnitus handicap inventory. And here's 4 questions, and you can see, does it make you angry? Does it cause problems with insomnia? Does it make you depressed? Are you anhedonic, having trouble, enjoying life with it? So tinnitus can be quite miserable. Here were their outcomes. I believe they used the tinnitus handicap inventory for this, and even at 12 months follow-up, at least 3/4 said they would recommend it. They had improvements in severity even at 12 weeks. In her case, she had hers was gone, which was amazing there. So several years ago, TENS devices, TENS units, transcutaneous electrical nerve stimulation came out. And it used to be that you had to have a doctor's prescription for the unit, doctor's prescription for pads. You had to go through insurance and all of this kind of stuff. And these are low milliamp devices. So was the linear device for the tinnitus. And now our favorite online marketer, you can get one in a couple of days for about $27. And they're very useful still for pain, but that is going away from the psychiatric. Of course, you improve pain, you improve your mood. So now this is a very interesting one where this is a study from China. Well, it's a single case report from China. And this is an unfortunate man who had a pituitary tumor in the brain, and he had brain surgery, was resected, and something went wrong, and he lapsed into a coma. And nothing got him out of it. And his wife was really, distraught and frantic about it. And they tried hyperbaric oxygen, comprehensive sensory stimulation. Interestingly, the median nerve, which is in your arm right here, stimulation, drugs, nothing worked. And she gave them permission to try something. So they stimulated the trigeminal nerve. There's 3 branches, the ophthalmic branch that comes out above the eye. There's a maxillary branch and a mandibular branch. When you go in to see the dentist, he or she is injecting into those maxillary or mandibular branches with that long needle to numb you. They did it 18 to 20 milliamps, which is a lot more powerful than the typical 2 or 3 milliamps for a TENS unit or the Fisher-Wallace unit, things of that nature. And they did it at 40 hertz. 40 hertz seems to be important, that number, and we'll talk about that in the end, for maybe activating certain circuits and microglia. And they did it continuously for quite a while. They did it 6 hours a day. His Glasgow coma scale was a 7, indicating coma. And at the end of it, at 4 weeks, it dropped to 11, raised to 11. And 2 more weeks, at 6 weeks, he was awake and alert and oriented. 15. Here's the Glasgow coma scale. And you can see 8 or less is coma. And he was a 7. And now he's fully awake, oriented to person, place, and time, and obeys commands. So that, could that have been a coincidence? Maybe. it is you got to always try different things and use it on different ones. This is the only report that I'm aware of. You can also use sound waves. There's something called transcranial focused ultrasound. This has been FDA cleared for OCD. I think you're going to see that's not something you would sign up for lightly. Here was one where and this is able to reach specific areas very deeply and destroy them basically. It probably works better for like deep brain stimulation for Parkinson's and tremors than it does for psychiatric conditions. But the Yale-Brown Obsessive Compulsive Scale went down pretty significantly. The Hamilton Depression and the anxiety went down. Gosh, you remember the old GAF score? That went up. And so basically, they found that by doing this in rats at 40 hertz, you could actually get rid of beta amyloid, which is deposited in Alzheimer's disease. And here was how they did it in rats or mice. And they were able to get deep in there and clearing out the amyloid plaques on that. So this is the first person that has been studied for depression for this in New York, I believe.
At 68, Linda Bonin has spent decades not being able to work, travel, or enjoy simple pleasures. She is essentially housebound. Worse, she is trapped inside her depression and anxiety.
I've had depression on and off most of my life, but it's been mostly on for the past 30-odd years. And we've tried every treatment in existence.
But nothing has worked to lift what she describes as this insidious disease. That may soon change. Linda is the first patient in North America to undergo an incision-free form of brain surgery for treatment-resistant major depression. Called MRI-guided focused ultrasound, it uses ultrasound beams to heat and destroy the precise areas in her brain causing depression. On the day of her treatment, Linda's hair is shaved and she is fitted with a frame, which is then attached to this specialized helmet housed in an MRI.
All right, we're going to do the first sonication now, okay?
With her head secured, her medical team can plot the precise treatment path of where the ultrasound beams will target. A newer imaging approach called diffusion tensor imaging, or DTI, paints a stunning portrait of the brain circuitry.
And this offers us the opportunity to look at which circuits are functioning, which circuits are not, and when we do the kind of treatment we're doing with focused ultrasound, to see which circuits we turn off.
After several hours, success.
So this is the original lesion here.
These two white spots show the treated areas. Linda is the first of 6 patients at Sunnybrook who will undergo this procedure for depression. It takes about 6 hours, and patients go home the following day. Over the next year, researchers will follow these patients closely to see if the procedure is safe and helps improve symptoms. That's been the case for a few who have already received this treatment in Asia.
Now there's an opportunity to investigate less invasive, potentially safer means of generating lesions in the brain, so for those patients.
And the need for new options is immense, says Dr. Levitt.
We're talking about maybe 2% of the population have recurrent treatment-resistant major depression. It's a major public health issue.
MRI-guided focused ultrasound is already an approved treatment for patients with essential tremor disorder. It's also being studied for several other conditions. Linda says she's grateful to be on the cusp of a new treatment and is hopeful for slow and steady improvement in her own life.
I'd like to be able to travel more and be more sociable, do some entertaining. Just everyday things that people who are well do.
With Sunnyview, I'm Monica Mattis.
So Dr. Stephanie Vanderpool, who kindly accepted the challenge to talk about neuromodulation for pain on the Wednesday talk, referred a patient that had a thalamic stroke that nothing helped She has burning pain over the left side of her head. There's a small study that TMS helped over the motor cortex, and we treated this lady, but it takes about 8 weeks to see the results. And she did go to, I believe it was West Virginia at the Rockefeller Neuroscience Institute, and they treated her with that, and she said it's a very arduous procedure. Unfortunately, it didn't help. You have to have an ice bath cooling your head, and you have to be very still with this thing screwed in your head for 4 or 5 hours. And it unfortunately did not help with her. So I'm going to end up with what I consider kind of the most exciting thing, and this is called photobiomodulation. And by using particular wavelengths of light, the red and near infrared light, you can actually penetrate the skin, skull, and the brain. It was done with lasers, but they found out those class 3 lasers only are you have to have a special ability to prescribe that. But they found out that you could also do with light emitting diodes, which are off the shelf. They activate ion channels and do a lot of things in the mitochondria. The mitochondria are our energy producing organelles within the cell, producing vasodilation, and is actually quite inexpensive. So how does it work? It works on chromophores. Probably the best known one is that we get vitamin D by sunlight acting on chromophores in a type of cholesterol in our skin, and it produces vitamin D. And they absorb specific wavelengths in there, and they can turn on and these molecules excite them and produce changes. So red light works on something called cytochrome C oxidase. This is in what's called the electron chain transport. You produce NADH in the Krebs cycle. You remember memorizing that in biochemistry? And then with the NADH, you can produce ATP, which is adenosine triphosphate, giving you energy. It also, the near infrared light works on heat-gated ion channels. Green and blue light work on rhodopsins and things like in the retina. And by doing this, you're going to activate it. Now, this cytochrome C oxidase is blocked by nitric oxide, and the infrared light moves that out. Nitric oxide, you may have heard of, is a vasodilating signaling compound, probably best known for sildenafil or Viagra's use for vasodilation and erectile dysfunction, but it plays a role in the brain. And by getting rid of this kind of clogging of that, it allows the ATP production and also allows what are called reactive oxygen species to occur as well. So here's a really great video about this.
We've had the opportunity to work with 2 football players, retired professional football players, and do the LED therapies. The first football player is 65 years old when he came to us, and he had played in college football and high school football and Pop Warner football since he was 10. And he was a middle linebacker. And he probably sustained thousands of subconcussive hits because that's what happens when you play football.
This is the Neuro's transcranial headset. The clusters were designed to target the brain's default mode network. In neuroscience, the default mode network is a network of interacting brain regions known to have the highest amount of activity correlated with each other and distinct from other networks in the brain. This is the Neuro's intranasal applicator. The high-impact polycarbonate lens has a built-in divergence of 57 degrees to focus the pulsed infrared beam towards the underside of the brain.
And I explained to him the mechanisms of red light and near infrared light and the effect on the cells, that they can help hypoxic or compromised cells to make more ATP, which is simply adenosine triphosphate, the battery pack for cellular function and respiration of those cells. And he understood that because he had a PhD in sports physiology. And so he listened to me and I explained the mechanisms that we knew about. And he thought that made sense. And he decided he would enroll in our research project. And the other part that he understood was that the reason there was low ATP production in these hypoxic compromised cells is because the mitochondria are clogged up with nitric oxide and they just can't make enough oxygen to function normally, but they're not dead. These cells are not dead. They're just not functioning well. So he agreed to come to our research project. And one other thing to remember about the nitric oxide clogging up the mitochondria is that when the red wavelength of light, you can see that, and when the near infrared wavelength of light, you cannot see that, but when those two different wavelengths, or either one of them, is applied to a cell that's not working well, those are taken in. Those two wavelengths are taken in by the mitochondria. And now, the first thing that happens is the nitric oxide diffuses outside the cell and promotes all this new blood flow and blood vasodilation. It's a wonderful thing. And the mitochondria start to make more ATP. So you get these two wonderful things going on just by applying red and near infrared wavelengths of light. And then we tested him. 1 week after that 18th treatment, he had done very well. He improved by 2 standard deviations on several cognitive tests. And the thing he was so happy about, and his wife, was his emotional outbursts had gone way down. His PTSD, as it were, post-traumatic stress disorder, was way down. And that was wonderful for him, because otherwise he wasn't able to control those emotional outbursts. So it was very good at 1 week after the last treatment, and even at 1 month after the last treatment. Now, but at 2 months after the last treatment, no LED treatments for 2 months, his symptoms started to come back. Now, that's probably because he may well be on his way to dementia and chronic traumatic encephalopathy that the football players can develop. But by 2 months, no LEDs, no red near infrared light in between, he's plummeting. So that was the end of my study, because I was really officially studying what happened after 3 months. But he decided he was going to buy his own equipment and he's going to treat at home, because the quote to me was, "I never want to go back the way I was when I first came to you." And he was really very unhappy and looking at a very bad future. So he did that, and he ended up buying this Neuro Gamma device that is specifically designed to only treat certain parts of the brain that we finally learned are the most important ones to treat, especially with progressive neurodegenerative disease. Of course, more studies should be done. The fifth area is through the nose to get to actually an indirect way to get to the hippocampus. And we're going to deliver the near-infrared photons, we believe, to right behind the eyebrow. It's the olfactory bulbs where your sense of smell is located. And that area, the olfactory bulbs, has direct neuronal connections to the hippocampus. Everybody knows the hippocampus. It's very important for memory. So it's a little difficult to directly get to the hippocampus because it's very deep in the brain. So we're going there in an indirect manner. And you know, in Alzheimer's disease, one of the first signs of Alzheimer's disease is loss of sense of smell. And that's because the olfactory bulbs, sense of smell, have lost connections down into the hippocampus area and no longer making new neurons, neuronal progenitor cells. The origin for that is in the hippocampal area.
they discovered that 40 hertz was necessary to clear beta amyloid out of rats' optic cortex to do that. So here are his scores. You could see his PTSD scores went down. Back depression inventory 40 is, I think this is incorrect. I think these are actual scores. 40 was very severe major depression, and it went down to total remission. 0 started climbing back up. His PTSD started climbing back up, and with his post-treatments, doing it at home, it did well. California Verbal Learning Test, you're given 16 words from 4 categories. You get 5 trials, and how many words you can recall at 20 minutes. And he did quite well, you see. The Stroop test is another neuropsych testing. So let me finish by telling you how to be your own researcher. There is this wonderful thing called the Preston Medical Laboratory at the University of Tennessee Medical Center in Knoxville. If you go into the hospital, you will pass it. There's a wonderful lady there named Laura Wolf, and everyone viewing this is now able to correspond with her and get articles for free with some exceptions. You can use PubMed, Google, other searches. You can look up and see if the article is free. There's PubMed Central and a few other, like some of the free, some articles are free through things like Elsevier. But if you come across one that you click on it and there is no free article, you're gonna have to pay for it. Don't ask to give you free articles, ask for the ones that you need for pay. And you do it by going to the reference, clicking on that, and then you can click on the cite button right here. If you don't want to pay, right here, and it's going to open up the citation. You click on the copy, and then you write this wonderful lady, Laura Wolf, at utmck.edu, University of Tennessee Medical Center in Knoxville, and you need to be polite. I always say, please give me this article, happy Tuesday, etc. And you put that citation down, and she will send it. Sometimes I can get it in 10 minutes. And that's if you don't want to pay $35 for something. If your back's against the wall and you got a deadline in the morning and it's 10 at night, you know, and Laura's not answering your email, then you have to fork up some money for that. So some require interlibrary loan, and you may get refused for that. You're going to get access to a PDF file of the slides here with hypertext links that you can click on for most of the videos that I've shown you and some other things. And with that, I am going to conclude. And I want to say thank you very much. And now you don't know what you don't know, but now you know. So I'll entertain some questions now.
Well, Lane, it looks like it's you and me for a minute before we get Cliff Tennyson. So I hope that's okay. Oh, there's Cliff. Cliff, have you got some good questions lined up?
Oh, more than I can count. Lane has been getting so much good press today. I don't even know if we need to ask him anything else. But, so let me ask a couple that are going to be real simple, and then we'll move on to harder ones, perhaps, that even Dr. Cook could suggest. The first easy one is, which diagnoses do you use for repeated transcranial magnetic stimulation? And if you could, do you use in your outpatient practice? And what have been roughly your overall findings for response, recovery, remission, etc.?
The insurance, all the commercial insurance and Medicare require severe major depression. There's 1 or 2 exceptions in the commercial insurance that allows moderate, so that good old F33.2 code of severity. And that's based on either a Beck depression, a PHQ, or a Hamilton. We've treated some bipolar patients. It's considered off-label and insurance doesn't pay for it. I'm sorry. it certainly works, but insurance won't pay for it. And sometimes we run into problems because people somewhere along the way got a bipolar diagnosis, and I certainly see plenty of people who are misdiagnosed bipolar or underdiagnosed. We get approximately 50% remission. Some quarters it's up as high as 55%. We get 67% response rates and 77% better. Throughout the country, there are people getting numbers even higher, maybe 65, 70%. Some places are combining CBT with it. The other thing is I probably don't get as high as some other ones because I mainly treat other people's patients and I don't adjust their medications. I make suggestions. I love lamotrigine, and there's one study showing lamotrigine may actually enhance the effects of TMS. So that's basically it. So about 22% don't get better, and that's a sad day.
Speaking of antidepressants, you mentioned how, or a slide did, how they lose efficacy over time. How can that be? And how is that different or the same as the tolerance with the substances of abuse?
Every time I see an expert, I used to ask this and I got tired of asking, I say, why do antidepressants lose benefit? And they shrug their shoulders and say, we don't know.
Okay.
It's not tolerance. And the simple reason is that, you know, Cliff, you and I, we're treating somebody with 10 milligrams of Lexapro and they're in remission. That's great. And maybe 9 months out, they start having symptoms of depression and we bump them up to 20 milligrams and they get well. But maybe 3 or 4 years from now, they start getting depressed. And, you know, the FDA approved is 10 to 20. I've used 30. Usually you don't get much better. You start increasing that dose and you do not get any change. If it was true tolerance, you could just keep increasing the dose. So it's not exactly tolerance. There is some sort of escape or long-term depression. We just don't know. But, you know, there are lucky people that have been, you know, remission for decades. So those are the lucky ones.
2 more that are not specifically highly technical, and then we'll move into some technical ones if you don't mind. But sure. This one is about people who might want to make referrals, psychiatrists, psychiatric nurse practitioners, or even psychosocial professionals. And here's one. This is with regard to when to know how to refer for RTMS based on antidepressant failures. So what is the definition of a failure if you have to have 4 for insurance? You said 2 to you actually indicates treatment resistance, but 4 for insurance. How would a person out there treating somebody know that this is going to qualify as a treatment failure on an antidepressant?
If they don't have at least the response. And generally the people we treat aren't at anywhere near response. They're in severe. Their rating scales are very high. And so, you know, Mark George and Harold Sackheim showed by looking at the STAR-D trial that you have this dramatic drop off after 2 antidepressants. And they made the case that that's really treatment-resistant depression. And the TMS providers that I know, that's what we say too. My typical TMS patient's been on 8 to 10 antidepressants and augmentation, and probably half have been depressed since childhood. If somebody has severe depression, the antidepressants and the therapy are not working, that, you know, they have insurance or we do treat some people for cash. It's not inexpensive, but that's who you refer.
Okay. So there's not a particular time span that the insurance companies use to say, were they on the antidepressant for X amount of time?
Well, I'm glad you said that. Many of them actually, it's really a documentation nightmare sometimes, because, you know, ask somebody, what have you been on? And they give you a list of 10 medicines. Well, when did you take that? I don't know, you know, in the 90s or something like that. And some of them, like Blue Cross, they want the dates, and so you have to use some creative writing, and the doses. And they want to know, did you use 50 milligrams of Zoloft when the dose is 50 to 200? And I've been turned down on some that they were using, small doses or, not an adequate amount of time. The other thing is that it's also if you're intolerant. One of the first persons we treated swore that every antidepressant made her hair fall out. And she went into remission with TMS, and she just said, "I'm not taking medicines that makes my hair fall out." And said, "I don't blame you. I could sympathize with that." Sorry. Anyway, so also it's intolerant. So they might have tried 2 antidepressants, and things like sexual dysfunction qualifies as intolerant.
So when someone's making a referral and there's been an adequate amount of time at an adequate dose under any reasonable determination, does it help for the therapist or the physician to have done just your routine depressive rating scales to be able to show the lack of response, or can you just use symptomatic descriptions?
Well, rating scales, we don't use them enough, as we know. And here's the funny thing. The way I do it is I have a wonderful coordinator, Terry Chumley. He does a phone screen, he gets records, and he screens out people that, if there are certain contraindications like epilepsy, shrapnel in your head, different things, cochlear implants. You don't want to fry those. And we do a PHQ-9 over the phone. And then we come in and they do it back, and sometimes we have to use a Hamilton. Here's the funny thing. Blue Cross, I'm not picking on them, but sometimes they can be more picky, wanted rating scales from therapists. And there are not many therapists. In fact, if you're a therapist using rating scales, you're at the 99th percentile. And we even sent PHQs to some therapists and they wouldn't fill them out, get the patients to fill them out. And one of my colleagues in Nashville said, "Find me a therapist that uses rating scales." And Blue Cross called her back and said, "Go ahead, we'll certify it." So, we do our own.
Okay. Here's an easy yes or no. Are any of the percutaneous electronic nerve stimulators available as in-home devices? This would be like for the opioid withdrawal.
Yeah. There was a mistake in my talk about that. I said the battery lasts 5 minutes. I'm wrong. It lasts 5 days. The percutaneous, I'm not aware of. The transcutaneous, the one that Mark George had on, and they're not FDA cleared, but I mean, you can get like the Fisher-Wallace device, different things, the transcutaneous ones. And I think they're pretty good for like real mild cases of depression and anxiety and insomnia. I didn't talk about sleep, but there's some interesting things going on with sleep, even cooling pads for insomnia. So there are different things that when you're going and sticking needles in there, that's when you have to have a healthcare provider to do that.
And then I was kind of thrilled myself with the ADHD, the response to ADHD symptoms, similar to Strattera, not as good as Vyvanse or Concerta, but with the trigeminal one.
Yeah.
What about our team?
The Monarch device, I forgot to say that, I think it's about $995, and kind of like the old TENS units, you have to buy the pads from them every so often. And I try to find if anybody is using this in town, and I put my email out there. If anybody's using that, any child psychiatrists or psych nurse practitioners using it, I'd love to hear about it and love to hear that. And because it's not approved in adults, you're not going to get any information back on that from the companies.
What about RTMS for attention deficit?
It works, but it wears off. The same thing for auditory hallucinations. TMS works for a lot of things. There's the BrainsWay does some wonderful jobs for Parkinson's. It wears off quickly. The treatment for depression is very durable. Depression is definitely the best thing that TMS treats.
Do you,
Dr. Cliff, I've got to cut you off. We've gotten out of time. Lane, thank you so much for all you do, and thank you so much for this wonderful presentation. It was great. We've got a break from 1:30 to 1:45 when we come back, and we have Dr. Malatek. Hey, I've got a pro tip for
Hey,
you.
You can get one of these for $1,700, and some of us are getting kind of old, Ben. If you want to kind of clear out the amyloid, you come see me.
I hear those grow hair there, Lane.
Not yet.
Yeah. So I've got a pro tip for anyone who's going to go to the virtual exhibit hall. Turn on your camera and your microphone so you can enhance your experience and have live interactive conversation with your vendors or your other attendees. So we'll see you back at 1:45, I believe, with Dr. Malatek. Thank you very much.
See you. Thanks.